All right, so now we're going to go on to our organizational updates. I'll start off by providing an update on CHoSEN Quick. Kylie Hipschman is unfortunately ill today, but do not fear. We have Katie Breen with us, and she will provide an update for the Colorado Perinatal Care Quality Collaborative. Katie is the Vice President of Programs for CPCQC. And then we'll have Kathryn Wells, who will provide an update related to the work being done in the Kempe Center, as well as here on our campus. And then Jade Woodard, who is the Executive Director of Illuminate Colorado. So let's get started with CHoSEN Quick. So that's the quality improvement collaborative of this broader CHoSEN work that we're doing. So this should look familiar to many of the hospital-based workers here in the audience. This was the big paper that was published all the way back in 2017 from Yale, lead author Matt Grossman. First time we were introduced to Eat, Sleep, Console. And so this was the big publication that launched a lot of enthusiasm and interest around a different care model for supporting families and newborns affected. Here it was really around opioid use disorders. Interventions were really focused on optimizing non-pharmacologic approaches, engaging families early on, improving communications and cross-systems collaboration. That was 6 years ago. Fast forward, April 2023. This is the first multi-centered, large randomized controlled trial of Eat, Sleep, Console published in the New England Journal of Medicine. So this is like, for those in academics, this is like the holy grail. Like you lead a big trial and you get published in the New England Journal of Medicine, you can pretty much retire from here, right? But this is 6 years later, people. This is like 6 years later, finally, this paper comes out, right? And they show, what do they show? What we already knew. Eat, Sleep, Console reduces length of stay, reduces pharmacologic treatment, and does not lead to increase in adverse outcomes, at least short-term adverse outcomes. The concluding paragraph of this article says, further study of potential contributors is warranted and will further inform how this care approach is then operationalized. And they talk about site variation, location, etc. Well, that's what we've been doing for 6 years. And in fact, that's what was highlighted by Dr. Wanda Barfield. She is the Director of Reproductive Health at the CDC and provided a commentary to this April 2023 publication in the New England Journal. And she says, since the publication of the first Eat, Sleep, Console quality improvement effort in 2017, perinatal quality collaboratives in Colorado and Massachusetts have already disseminated the approach and standardized the care of infants with neonatal opioid withdrawal syndrome for nearly all birthing hospitals in the state. And so I think we've been way ahead of the curve, and we've supported thousands of infants and families during that time. And so I'm going to show you some of the data. So this data reflects the data from the start of CHoSEN Quick 2017 up until second quarter of this year, and reflects over 2,000 substance-exposed newborns, 2,000 since the publication of that 2017 quality improvement paper. As you may recall, we collect limited sociodemographic information. Shown here are maternal race and ethnicity breakdown for our CHoSEN Quick cohort. You can see that the majority, 2/3, are non-Hispanic, and about 2/3 are identified as white. Lots of missing, right? For race, we have 25% missing for race. Still a problem when you use EPIC or electronic medical record data. Here are one of our primary outcomes, length of stay for all substance-exposed newborns. And we include infants greater than 35 weeks who don't have any other diagnoses that would impact their length of hospitalization. We continue to maintain and sustain this reduced length of stay. We started off at close to 2 weeks, and we've been at about 7 to 8 days. There's a bit of variability in more recent quarters as the number of families and hospitals, contributing data to the system has declined. But that being said, there has been sustainability. Here we have the percent of opioid-exposed newborns that receive pharmacologic therapy during their birth hospitalization. We see that there's somewhat of a sustained decline. We had the majority of our infants, over 60%, that required pharmacologic treatment. That came down to about 20%. You'll notice, though, recently, there potentially is an increase, and we're keeping an eye on that. And anecdotally, what we're hearing from hospitals is increasing exposure to fentanyl as impacting how we treat the opioid-exposed newborns, that Eat, Sleep, Console may not be as effective as previously. that the withdrawal that we're witnessing with fentanyl is different and requires, in fact, early and at times higher doses of pharmacologic treatments. Here we have the percentage of eligible substance-exposed newborns that received mother's own milk, and this is declining. And so while we talk about sustainability and continued engagement, we know there are some process and outcome measures that require a deeper dive. We need to understand why this decline is happening. I can't give you an answer today, but I really rely on the birthing hospitals who are at the front lines to better understand who are the birthing individuals and their infants that are not being breastfed or being discharged with mother's own milk. And so this was our paper that was published back in 2020. We've transitioned from active implementation to sustainability for those hospitals where Eat, Sleep, Console is truly standard of care. And so we've developed some criteria to assist hospitals to self-assess whether or not they're moving into sustainability and what that looks like. If you think you're one of those hospitals and you haven't yet reached out to us, please do so today, and would be happy to schedule a site visit to better understand where you're at and how we can support you during the transition. That being said, we had some great success, but as highlighted by this commentary that was offered to our 2020 paper, there are limitations and our work must go on. And so what this author writes is the most notable limitation of this work is the absence of post-discharge outcomes. That includes, but are not limited to, hospital readmissions, as well as the experience of the families after discharge. And what are some of the balancing measures? What are the unintended consequences of the work that we've done? And really, this is a great transition to what we're proposing to do in the coming years. I wanted to highlight a recent paper that was put forth by Stephanie Bork, one of our steering committee members, that looked at the prevalence and predictors of early intervention referral among substance-exposed newborns. So this includes about 1,200 maternal infant dyads within our CHoSEN Quick data system. And she sought to understand what were some of the factors that were associated with birth hospitalization, early intervention referral. First of all, she demonstrated that only 41% of these infants actually had an EI referral in place by the time the infant was discharged from the birth hospital. And some factors that she identified: that infants born to mothers with non-MOUD and polysubstance exposure were less likely to receive a referral. Those with private or self-pay or no insurance were less likely than publicly insured. Now, we don't really know the inner workings, the how or the why behind these results, but what we've clearly demonstrated is that there are those that are not receiving the service or not receiving the referral to the services. And in fact, we've identified independent factors for it. So there's clearly biases here at play, right? So there are those that are getting referred and those that are not. This is at the hospital level. So this is what we need to better understand. Also demonstrated were the wide variability in EI referral rates by hospital site. So each column here represents a birth hospital and referral rates. So whenever you see this much variability, it really highlights the need for standardized approaches, participation and quality improvement collaboratives to learn from each other so that we can narrow these gaps. And so where we're continuing to struggle, I was going to say a failure, but let's call it an area of opportunity, right? If we take the growth mindset, shown here are the rates of our CHoSEN Quick mothers that are receiving or have documentation of receipt of medication for opioid use disorders. That hasn't changed since 2017. That literally has not changed. So we should be seeing an increase, right? With all the work that we're doing, we should see more mothers engaged in treatment, and we haven't shown that. Here we have the percentage of substance-exposed newborns whose families received a documentation of a prenatal consult related to care of their newborn that was prenatally exposed. These numbers are pretty abysmal. And again, I highlight every time that this is likely a documentation issue and that these families are not getting what they need in terms of anticipatory guidance and preparation. Here we have the percentage of substance-exposed newborns who received a warm handoff to a primary care provider. Perhaps we saw a little bit of an increase, 2019, 2020. Then most recently, we actually went in the wrong direction. Whenever you see a new mean right here, ideally it's an improvement. And our new mean has declined. And so we have to think about what are the barriers, what are the systems level issues that are preventing our frontline workers from establishing relationships and giving warm handoff to those that'll be caring for these infants in the outpatient setting. So what I've highlighted here is that the work has to go beyond the birth hospitalization. And while CHoSEN 1.0, the work that we started back in 2017, was really geared toward birth hospitalization with eat, sleep, console, non-pharm therapy, standardized and pharmacologic approaches, our next iteration, the 2.0 version, is focused on optimizing transitions. How do we increase outpatient provider engagement? What are plans of safe care? Many, many definitions of that. We're going to talk a lot about that today. And how do we think about implementation? Toxicology testing guidance, perinatal cannabis use guidance, naloxone distribution. So really focus on transitions. This is our updated key driver diagram. I'm not going to go into detail here, except to highlight that each of these key drivers are going to be addressed in the afternoon workshops. So if you want a deeper dive on what I've just highlighted are the focus points for the 2.0, so much to learn in the afternoon. So I hope that you will stay and engage in this 2.0 effort. And so with that, I will now pass it over to Katie, who will provide an update on CPCQC's work.
Hello, good morning. So as Susan mentioned, Kylie was supposed to present for us today. She's our new and amazing Director of Integrated Behavioral Health, but she has a stomach bug, so you have me instead. So I'm Katie Breen. I am the CPCQC Vice President of Programs. So how many of you know what CPCQC is? Okay, that's pretty good. But I'll go over it really quickly. So the Colorado Perinatal Care Quality Collaborative. So we are the state's perinatal quality collaborative as designated by CDC. We're also legislatively authorized to implement the Maternal Mortality Review Committee recommendations related to clinical quality improvement. So that is sort of the perspective that I come at you with today. And then we also, if any of you are familiar with the Alliance for Innovation on Maternal Health, we are the agency in Colorado that implements AIM bundles. Our QI programs encompass L&Ds, NICUs, and communities. And then we do lots of other work around maternal mental health and just generally convening any sort of perinatal health, neonatal health stakeholder in the state. So that's a quick rundown of what we are. Susan touched on this earlier, but there was a new Maternal Mortality Review Committee report that came out about a month ago, covering all deaths in Colorado between 2016 and 2020 that occurred during pregnancy and up to 1 year postpartum. And 1/3 of all pregnancy-associated deaths are due to unintentional overdose. And mental health or substance use disorder was a contributor to 1 in 2 pregnancy-related deaths. And even more of the deaths that weren't even attributable to substance use disorder or mental health conditions. So, for example, someone who might have died of an obstetric complication. Those deaths, 1 in 5 of those decedents had a substance use disorder or maternal mental health conditions. So obviously, this data is showing us there's so much more work to do in Colorado to improve maternal mental health and substance use disorder. And the bottom part is, really why we're here today. 100% of maternal deaths due to accidental overdose were preventable. So that's what we're here to work on. And of course, to care for the neonates also affected by exposure to substances, but that's why we're here. CPCQC has lots of programs. We partner with university, of course, on CHoSEN as a NICU initiative, and then also Define, which for some reason I think got cut off on this list, but we apologize. We love Define. But I'm going to focus today on our behavioral health initiatives because, again, we are all here today essentially to talk about behavioral health. So the main programs I'm going to talk about today are related to preventing maternal overdose. Now, I know that most of you are working in the NICU, but of course, what Susan was talking about transitions of care and needing more integration. Those of us who, work a lot with L&Ds want to make sure that we're also really closely working with NICUs because of course the dyad is in both settings. So that being said, while the programs I'm going to go do a quick overview of right now are L&D focused, that does not mean they are L&D exclusive. We very much want to integrate more with NICU people, and all of the resources we offer are also very relevant to the NICU community. So that being said, quickly, two of the maternal substance use disorder initiatives that we work on. One is called COAIM-SUD. That stands for the Colorado Alliance for Innovation on Maternal Health Substance Use Disorder Learning Collaborative. So COAIM-SUD is not a pretty acronym, but you can see why it's an acronym. And that is about really perinatal SUD care 101 for L&D units. And it's implementing the AIM patient safety bundle for patients with substance use disorder. And then we also have a new initiative in the last year that we're really excited about called Moms Plus. And that's sort of what we're considering as perinatal SUD care 2.0 to COAIM-SUD's 1.0, or sorry, 101 to 201. So 201 really goes further into harm reduction, naloxone, and then treatment and referral to care and connection to community. So we're really excited about this. They are very closely intertwined. They have a shared QI approach and data. And so while they're sort of the 101 and 201, we really manage them in a streamlined fashion for our participants. So we're really excited about these programs and we're happy to tell people more about them. And even if you're like, well, I work in the NICU, is there a place for me? The answer is absolutely yes. So, just another quick primer on those two programs, COAIM-SUD and Moms Plus, which are the L&D focused ones. So there we have 20 hospital L&D units currently. That accounts for 39% of L&D units in the state, but 53% of Colorado births. So we're making headway. We're also in 100% of the regional accountable entities, just to show you that we do have statewide distribution and we are trying to get into even more hospitals. If you are curious, we have public cohort data dashboards where you can check out how the outcomes are doing. And then, of course, we do actually have private hospital-specific data dashboards for hospitals to track their own improvement. But anyone is welcome to take a look at the outcomes we're tracking and how we're doing on them. We also, and I apologize for the formatting, do lots of things to provide resources and support even outside of 101 QI, but resources and tools to help people implement, whether you're actively participating in the QI or not, you can use these tools. So one such is a model hospital policy for perinatal substance use. This is based on the best practices outlined in the AIM patient safety bundle for SUD. And it is something that any hospital can take and use as a guide for how to screen patients as they're admitted for birth for substance use disorder. And then if a patient screens positive for substance use disorder, how to make sure that they are comprehensively cared for, referred for, offered treatment, offered naloxone and harm reduction. And then related to that, Susan touched on this earlier, but Support Colorado recently came out with model policy for indications for toxicology testing in Colorado birthing facilities. So this is something that we also are very excited about. We also distribute to our hospitals, and anything that is about toxicology in this model hospital policy is based on Support Colorado's indications for toxicology testing. So we are very appreciative of many of the people in the room who worked on these, especially Laurie Helmo and others. And then another thing I wanted to say is that we really prioritize lived experience in our work through a couple of different ways. So we have our own lived experience integration program called FIRST, which is the family integration to restore trust. And that is all about ensuring that we're repairing relationships that we as a health system and industry have destroyed over the years. So that's really important to us. We also are really excited to partner with Heart Beauty, and we have lots of Heart Beauty people here today, and you'll hear from them later on our substance use disorder initiatives, as well as Tough as a Mother. We have people here today from Tough as a Mother as well. And we really are always trying to make sure that lived experience is at the heart of everything we do. And so If you are a lived experience expert that wants to get involved, or you know people, you are always welcome to send them our way. Next steps. So later today, you'll hear from Carly Swenson, who is going to talk about a nursing stigma and bias training that we are running this month. And we already have a wait list for future iterations. So you will learn more about that later, and you can sign up for the wait list. It's amazing. Definitely reach out to learn more about our substance use programming and how you can get involved or get your L&D involved if they're not already. Anyone is welcome to attend an upcoming monthly coaching call of CoAIM-SUD. Again, while it seems very L&D focused, it's also very much appropriate for NICU folks. And then you are always welcome to help spread the word about the FIRST program, which again is our program to integrate lived experience experts into all QI programming, as well as CPCQC leadership positions. And that is all for me, I believe. But any questions, you can email them to info@cpcqc.org, or I will be here today. And thanks for your time.
Thanks, Katie. All right. Next, we'll hear from Dr. Kathryn Wells and Jade Woodard.
Good morning, everyone. So I'm just going to say a few comments as I introduce myself, and Jade will as well, and then we're going to jump into some Support Colorado updates as well. I'm Kathryn Wells. I'm the Executive Director of the Kempe Center, which most of you probably know, but we're a center and a section within the Department of Pediatrics at the University of Colorado School of Medicine. And we are super excited to partner in many ways and to try to advance this work. We have a range of, we have 75 faculty and staff that range from direct clinical services all the way through research, evaluation, implementation, science, intermediaries, training and education, policy work, and really a justice, equity, diversity, inclusion lens is really our focus. Specific to this work, a couple of things that I just want to sort of, you're going to hear from Jenny Cook-Zappel later today in one of the breakouts around the CHoSEN Perinatal Navigator program, which is really to address these challenges around linkages, ideally prenatally, but then how do we do warm handoffs and connections for folks that we're working with in these systems, because you heard from Susan how important and how this is and how horribly we're doing, honestly, to link everything from all the connections, all the resources, all the things that families need, and then really thinking about how do we do that in partnership with peer supports, and how do we do that with the trusted supportive nurses as educators as well. So that's the Perinatal Navigator program. Also really excited, just in the last year, launched our KIDS, which is actually it's KICS, Kids in Care Settings. I'm getting Kids and Kicks. Kids in Care Settings Clinic, which is a clinic for kids in out-of-home placement, foster or kinship. So Dr. Berg Gilmartin and Dr. Jessica Kenny are leading that clinic with children's. It's a children's side of practice clinic. And really excited that kids that are born and identified as substance exposed that are not able to go home with their families, or either going with kin or foster placements, will be followed within that clinic. So CHoSEN it's such a great partnership to really be able to make sure those kids are getting early intervention and all the other needs that they have met with in that clinical setting, involving birth family supports as much as it's possible or safe. And so really excited about those couple of things. We have a new website, kempcenter.org. We have our very first impact report that's out if you want to learn more about the spread of things that we do, but just super excited to be partnering on this work, as well as with Jade on Support Colorado.
All right. Good morning, everyone. Jade Woodard, Executive Director of Illuminate Colorado. I'm very excited to be here and to tell you more about our work. Before we dive into support, I just wanted to mention a couple of Illuminate things. Last time I was here, so that would have been April of this year, I spent quite a bit of time sharing with you all about Family Connects, which is universal home visitation for all families upon the birth of a baby. You are going to hear more about that today in one of our breakout sessions. We also have some of our local implementation partners here. We are so excited about the data and research behind this model. 59% decrease in child welfare involvement, particularly for families of color. $1 on Family Connect saves $3 on emergency medical care in the first year of life. So many amazing outcomes. Can't wait to roll this out across our state. So love for you to hear more. We're going to share a little bit about Support Colorado. And then if you have any questions about anything, please feel free to chat with us throughout the day. Before, though, I have to introduce some babies to you. So we are missing two of our Support Colorado team today, Kelly Sutton and Jillian Fabricus. You have probably met both of them over the last couple of years. These two babies have joined us in the last 6 weeks. So Ada Sutton came to us on September 16th, 17th, and little Ansel Fabricus just joined us on Tuesday, the 18th. So we are so excited to introduce you to our babies. Kelly and Jillian will be back in January. They'll hit the ground running again. They love this work as much as the rest of us. But how could we not introduce you to these little beauties? Yes. All right. So if you aren't familiar with Support Colorado, we are the kind of steering committee that's been meeting since 2008. Dr. Wells and I have co-chaired it that entire time with a really intentional focus around prenatal substance exposure and how do we prevent, support, increase access to treatment, recovery, all of those different things that we know families need in order to encourage families to be safe and together. The gray bubbles on here are our priority areas. These are the same priorities we've had for 2022 and 2023. And then the purple bubbles are the spaces where that work is happening. So we have a family advisory board, our plans of safe care work group, an FASD awareness work group, data and research advisory group, policy analysis, our provider education group. Several of our chairs or co-chairs of those groups are in this room today. So thank you all. And then the steering committee and family advisory board really are the ones that are holding the charge around our statewide capacity. So I'm going to turn it to Dr. Wells to tell you a little bit more about the details.
All right, so I can do it this way, I think. So the priorities areas for 23 as well as continuing from 22 are what Jade mentioned. So how do we reduce stigma around accessing substance use treatment and recovery supports for pregnant and parenting people? The worm handoffs that I was mentioning that we're addressing as well with the Perinatal Navigator program is making sure that systems and all the folks that work with them are developing practices and policies that really support those worm handoffs and standardized practices to address inequities. And really, honestly, how do we study that and how do we show impact, which is often complex because it's often across multiple systems. FASD work is really building that statewide capacity to identify fetal alcohol spectrum disorders and then support those families that are impacted. And then really growing statewide capacity to align efforts and apply lessons from our data. So how do we take what we learn and make sure that there is a capacity to apply that statewide? A couple current projects, you've heard a little bit about this already. So the work of the policy work group and the provider education work group was responsible for putting together the best practice guidance for toxicology testing. And then plans of safe care work group, the best practice guidance for plans of safe care implementation. And it sounds like we're going to be hearing a lot more about that today as well. Some state policy updates. And Jade, please jump in if you, many of you may be well aware that in addition to the opioid interim study committee, which you heard mentioned earlier, and Jade will talk a little more about in a minute here, the child welfare system has also had an interim study committee, or the legislature has held an interim study committee around child welfare system. That committee has been meeting throughout the summer. The last, I think it's October 25th, is next week, where what has happened during that time is they've heard testimony from a range of experts and groups and folks with lived experience as well. They've now culminated that into recommendations of 10 draft bills. You can see those at that link, and they will be selecting 5 that are guaranteed to be able to move forward. And it doesn't mean that the other ones might not move forward in another capacity carried by another legislator, but from this study committee, there will be 5. And you can see the sort of large topical areas. One is special provisions related to kinship foster care homes. It has to do with funding and resourcing the same way that foster care has been resourced. Behavioral health statewide system of care is one. Keeping Families Together Act is another one, and that has some definition changes around forensic consultant roles. temporary protective custody processes. And then specific and most important to this group, this bill would require informed consent for drug screening and testing of pregnant and postpartum persons and newborn children. That's some of the language in that proposed bill. Whole health coordination pilot program is coordinating all of healthcare, physical, oral health, and mental health for kids that go into out-of-home placement. And that's through a pilot project and studying it. High acuity crisis beds for children and youth. We know it's a real challenge in our state. That's what that's addressing. Accessibility for persons with disability or maybe language barriers in child welfare matters. Child welfare system tools and studying their effectiveness and what are the best tools. Child welfare worker task force that's looking at worker training, certification, accountability standards, requirement reports for child abuse and neglect. And then the last one is a commission on child protection that would sit within the Ombudsman office as a forum for proactive conversation. So that's a very, very high level, but 10 bills that'll be voted on next Wednesday. Those are all public hearings. I think it's going from 9 a.m. to noon. So if anybody, and then they're also online as well.
Yeah, and I'll just add, both Kempe and Illuminate are very engaged in this committee and offering lots of different feedback and input. We expect the version of the bills that's posted right now will not be the final version. Even if it is the final version, there will be an opportunity once the legislative session actually starts to have more input. So if you have thoughts or ideas, please do not hesitate to reach out to either of us, anyone at Support Colorado, and we can really talk you through how to have your voice heard and how to participate in the process around what's in here.
Absolutely. And as Jade said, I mean, even reaching out, Representative Mary Young is the chair of the committee. I mean, there are lots of ways to get your voices heard, and there is ability in that hearing to actually sign up for public testimony as well. And that will be heard prior to the voting on the bills.
You can keep that one. Okay, so opioid policy or opioid study committee. We have our lovely esteemed chair here. A couple of just quick comments on how this connects to the work that we do. So 5 bills coming out of this one. Final votes on this are Monday, October 30th. The prevention bill has a section around the statewide perinatal substance use data linkage project. You all have probably seen some of the data coming out of that in the past. It really connects our child welfare data, our state administrative databases. So our child welfare databases with our kind of human service databases with our Medicaid or private insurance or hospital data to really be able to look at trends over time for families and the outcomes that are associated with their kind of involvement in different systems. So we're really excited to continue to be able to support that, make a little bit of cleanup to the language in there. And then we have 2 other sections in the treatment bill, one that is appropriating money to the Colorado Child Abuse Prevention Trust Fund. They have a charge to reduce the occurrence of prenatal substance exposure, however, have never had funding for that specific charge. So we are trying to model what has happened in the past where they had a charge around child sexual abuse prevention and didn't have funding for it. So the general fund allocated $150,000 for that specific charge. We're trying to model that and recreate that for the prevention of prenatal substance exposure exactly the same way. And then we continue to work on and hear about access to childcare for families seeking substance use treatment and recovery services as a big barrier. And so we are looking to convene a stakeholder group that will create some recommendations on that, also housed within the Colorado Child Abuse Prevention Trust Fund. We are having some additional conversations around CCAP. And so that is our Colorado Child Care Assistance Program. It's our child care subsidy program. Essentially, CCAP has work or education requirements. If you are attending substance use treatment, you may not be able to meet the work or education requirements because of the time commitment of your treatment requirements. And therefore, you're not eligible for CCAP because you can't meet the work or education requirements. So we're trying to add participation in a substance use disorder treatment program as an eligible activity for getting CCAP. We're kind of working through the details of how we do that because it's a complex system, but Rep. Kennedy and I were just talking about it in the hall. We've got some plans. We're going to make it real because we know that families need that support. couple other bills in there. Take a look. Same comments as child welfare. They are on the website here. Public testimony is welcome. This is the date that it's happening. So sign up or let us know if you have questions or want to understand any of this more. I will just very quickly go over a couple of quick federal things. FASD Respect Act. Dr. Christina Uban is with us today. We were in DC a couple of weeks ago. We were meeting with legislators. Actually, the best experience of the day was when we saw Rep. Brittany Pedersen. Happened to catch her walking out of her office. And we said, hey, we're here to meet with your chief of staff about the FASD Respect Act. Christina's husband is affected by prenatal alcohol exposure. And we just had 5 minutes to tell her why this was so important. And she was like, oh my gosh, count me in. I will sign on today. It was like the only time I've ever had anyone commit on the spot to support a piece of federal legislation. It was very powerful. So this is really work around how do we do more education, awareness, diagnosis, and support of kiddos that are affected by prenatal alcohol exposure across the nation. And then we are also heavily advocating around CAPTA reauthorization. So CAPTA, again, is the Child Abuse Prevention and Treatment Act. There is a component of CAPTA that is specific to plans of safe care. That's where the work lives in federal legislation. In 2022, there was a bill to pull the plans of safe care section out of where it sits in CAPTA right now and create its own separate title, Title IV, which would be focused on the public health response to infants affected and really creating plans of safe care as its own title with a public health approach. We aren't sure if that'll move forward this year. It did not move forward last year. It got caught up in CAPTA reauthorization issues related to other topics. And so it did not move forward. We are advocating really hard to try and get that to move forward this year. So if you know John Hickenlooper, I would appreciate a phone call. I can send you a letter. You can forward it to him because really I think he's going to be our best in because he's on the HELP committee federally, which is the one that will hear this next. All right. Couple of last things. I know we're kind of short on time. The Plans of Safe Care pilot has been resourced by the Colorado Department of Human Services. It's really an opportunity for us to think about a higher level framework for implementation of plans of safe care here in Colorado, knowing that every community and every response will be unique to that community and the context that is there. So wanted to just kind of share that this work is underway. We will be piloting in the San Luis Valley. That is official now. They signed on a couple of weeks ago. And are really excited to share more about this. Kathy, I'll let you add anything you want.
No, I just think this is a great opportunity to think about ways to do this and then to test that. And then if that works well, to figure out how we can look to then, what would that look like to implement that in other places? How would we, using implementation science, thinking about readiness, thinking about what's available. So yeah, just a super exciting opportunity.
All right.
And so, I think Jade mentioned this before, but I just want to underscore, I think the strength of Support Colorado is really in sort of how we think about these different areas, right? So, utilizing data to drive policy and practice, to think about how that informs legislation, I think is really important. And then thinking about how we share measurement and in different ways, in different capacities. And, because this is not an issue that just is a healthcare issue or just as a child welfare issue or just as a justice issue. So I think that's been really, really important. Clearly having the voice, the expertise, the contribution of voice of those folks that are impacted in a variety of ways by these issues. I mean, to me, it's when you talk about hope and you brought that up, hearing the stories we hear today, and I am so bummed I have to run to the airport as soon as I'm done because this is such an inspiring day. And some of it really is the impact that we can have of people that are not others, as you heard said earlier, that are really us. Okay. Cross-system collaboration, that collective impact approach of how we all work together as systems and collaborate, sort of putting our agendas at the door and saying we're all better together, I think has been huge. And then really what I think has been one of the biggest strengths of Support Colorado is having a backbone organization that can help pull that together. Because many of you are probably a lot like me, we care so much about the work and we're busy doing the work that sometimes the ability to sort of put all that together is just challenging. And so it's often goes by the wayside, and that means that good work doesn't get continued. And that's, I think, a big part of why this has been continued.
All right. right. So I think with that, we just wanted to say thank you, please. I will be around all day. Members of the Support Colorado team will be around all day. We'd love to connect with you if you want to know more about any of these things, or if you have ideas of what we need to take on next. And we are just so grateful. Feel free to contact our team if you have any questions.
Thank you so much. You know, one of the best things about CHoSEN Quick is that we have been able to bring together legislative folks, those that work in the policy arena, those that are in the quality improvement arena. I remember the first time I met Jade and Jillian, this was probably 6 years ago. And literally I asked them, so like, what actually happens at the state capitol? Like, how do you this is what we need, like in the hospital. Can you figure out how to get us money? And so there is this huge disconnect between the work that happens at the front lines within the birthing facilities and the legislation that are passed. And even to this day, I still couldn't explain to you what you all do. But I am just so thankful that we can partner with Illuminate, with CPCQC to move this work forward.